So, Albert, good evening.
Good evening. Hello, everyone.
But your place is in good morning.
My place is early afternoon now.
Early afternoon, okay.
So, buon pomeriggio.
Oh, right. Very
More difficult, more difficult.
Okay.
Ciao is enough. Easier.
Oh, okay. Okay, ciao. Hi. So, Dr. Liu, how are you?
I'm good. I'm good. How are you?
Yes, both of you
Okay.
looks great.
Oh, now I can see you. Hi, Dr. Liu.
Hi, Liu. He joined all the webinar every night. Must be so hectic, I think. So Dr. Sarat Chandra is here?
I'm just messaging him. I don't see him in the panelist list. Meanwhile, since we are waiting for Professor Sarat Chandra, you could play our promotion video. Is it audible, ma'am, now?
Yes. So you want to start?
Yeah, maybe we can start since Professor Sarat Chandra will be the second speaker. So he can join and we'll introduce him after Professor Juha's talk. So good morning, good afternoon, and good evening, everyone. Welcome to the second session of our ACNS YNS webinar dedicated to build up the low resource countries, the neurosurgery capacity in the low resource countries. And today we have two legendary guest speakers, Professor Juha and Professor Sarat Chandra. Along with that, there will be two case presentations, one from Afghanistan and one from Myanmar. And we have our chief patron, Professor Yoko Kato, and co-patron, Professor Fawad Faisal. Unfortunately, Professor Matthew from Myanmar is not able to join today because of the situation there. Along with that, we have a few new joinees in our ACNS YNS committee. Dr. Alexandru Andruska from Moldova is there. Dr. Hemanta and Dr. Malinga from Sri Lanka is there. So with that small introduction, I would request Professor Yoko Kato to say a few opening remarks and then we'll start.
Thank you very much for the nice second time of the ACNS YNS, the monthly educational webinar. So today we are so honored to receive the two giants of the neurosurgeon. One is, of course, Dr. Yuha, no need to introduction. And also the Sarat Chandra, he is a specialist of the epilepsy or minimally invasive, the neurosurgery. So, and besides that, I'm so happy to see the young doctors from the Myanmar and also the Afghanistan. Besides that, and today is Moldavia, maybe, I think.
Yes,
so
Moldavia.
Yes, maybe the short introduction afterwards, I think.
Sure.
So we are very much looking forward to hear all the presentation.
Okay.
So, thank you so much.
Okay, then we'll go ahead. Then allow me to introduce our first speaker, Professor Juha. Professor Juha is born in a small village, Neimon, which is less than 100 inhabitants from Finland. So that is the map of Neimon. He finished his high school in Finland in 1966 in a very beautiful city, Rovaisi. In 1973, he finished his MD from the Zurich University, Switzerland. In 1979, he finished his post-graduation of neurosurgery and PhD from LNSD, that's LNS University. And from 1980 to 1997, he was senior physician and then co-chairman at Kuopio University Hospital. That's Kuopio University Hospital. That was his schooling and education. About his work experience, he has around more than 450 original articles at PubMed and mainly on the cerebral aneurysm and AVM and cerebral tumors. More than 200 reviews and textbook chapters. Has been editorial member and reviewer in the journals Neurosurgery and World Neurosurgery. About his operative experience, he has around study protocols at more than 25 centers, including Professor Yasserville and Professor Drake and Fearless. Personal microsurgical experience of more than 16,000 operations, including more than 6,000 cerebral aneurysms, 6,000 plus AVM and neuroarteriovenous fistulas, more than 3,500 brain tumors. Okay. He's a great teacher and mentor to many young neurosurgeons. Around more than 3,000 foreign neurosurgeons have visited Helsinki over the last 15 years, and more than 1,000 fellows have been trained under him. He has given numerous live operative courses around the world, including all the continents. He is the author of this beautiful book, Helsinki Microsurgery, Basic and Tricks. I'm sure every postgraduate and every neurosurgery resident uses and sees the video from this book. So a neurosurgeon with 47 years experience, included at different level of management responsibility of 1,000 to 3,500 yearly neurosurgical patients, approximately more than 70,000 patients treated in over more than 47 years. In December 2015, he was awarded with World Neurosurgery Cover and Inside, first one of the 69 top prominent neurosurgeons in the world. And the Joe Lee Net magazine has awarded him one of the 18 top neurosurgeons in the world in 2015. So with that introduction, I would ask the legendary neurosurgeon, Professor Juha, to kindly start his talk. Thank you.
Thank you very much. Thank you for very throughout introduction. I have to repeat some of the things. I go quickly over them. So I will speak about my life in neurosurgery. And it's of course difficult task, but I have tried to give some light in my life in neurosurgery. So this is the background. I was studying medical science in Zurich because I didn't come inside Helsinki Medical Faculty, so I had to go to Zurich, and this was a big turn in my life. And you will hear about that. Neurosurgeon, 79, same day, same year, PhD, and then 17 years in Kuopio, and finally 97 I became chairman in Helsinki, 18 years. And after my retirement, 2015, have been around the world, and then have been working in Peru, Indonesia, USA, Nepal, and now since 3 years in China. When I became chairman in Helsinki, 97, so on the first day when I came to the clinics, the chief nurse, old chief nurse, asked me, "Do you really think you can change here something?" And I didn't speak anything. I didn't answer anything to her, but I changed nearly everything in Helsinki, by far more than were my plans or in my highest dreams in the 18 years. So something about my background. I'm coming from Finland. Finland is the most northern country of the European Union with small population, 5.5 million people. This is Zurich, where I studied, and of course Professor Yasaki was there. I saw Professor Krayenbühl and Yasaki. That's why I became neurosurgeon. So this is old family picture. Small boy here, sitting with his mother is my father. This is 1923. And this is my grandfather here. Take a look, these are people are less than 40 years old, and they look so old and tired and hopeless. The times of financial economic depression, and the times were hard. What was coming? A lot of emigration to USA, Canada, Australia, and worse was coming. The Second World War was coming, and this is my father in war and my uncles in the war. 5 years in the war was my father. I was born 47 in Niemonen, Western Middle Finland, village with less than 100 inhabitants, countryside. And this is 1950, my family picture. I'm sitting with my father and my younger brother, 2+ years younger, with my mother. So after Second World War, there was a baby boom, like always after wars, and I was born in the heaviest year of this baby boom, 1947. We moved to Rovesi, also countryside, small town, and there was a general practice GP in Rovesi. He has made Einaref Palmen. He has made his lifetime work treating the people in this small community, and he became my first medical teacher. How? Both collected stamps, butterflies and coins. So we met, and this way I visited him often. And when I grow older, then he began to tell stories about his practice and his life as a medical doctor. So I became interested and wanted to be also a medical doctor. So, as mentioned, I didn't come inside Helsinki Medical Faculty, so I had to go to Zurich, and this was a big turn in my life because a country boy became European citizen, even world citizen, and I saw extremely high level university, medical school, and many famous professors, and I saw Professor Krayenbühl and Yasaki, and that's why I became neurosurgeon. During my study time, I was working in a brain research institute directed by Professor Konrad Agert. Here I'm operating on a rat brain with OPMI1. This is 96, more than 50 years ago, assisted by Professor Etsuro Kawana from Tokyo. He was a neuroanatome, and we made a small study on the subfornica organ afferent fibers. And this is my first medical scientific lecture. This is in Leningrad that time, nowadays St. Petersburg. This is in front of the famous Pavlov Institute. I'm here, my friend, professor of the Pavlov Institute, and then Professor Konrad Agert and Professor Etsuro Kawana after my lecture. My lecture was 5 or 6 minutes. I was very happy when 3 girls came after my lecture and asked my autograph. So this was very proud, very good performance. And this is my first day in Helsinki, June 1st, 1973, beginning my neurosurgical residency. That time it was allowed to smoke in the hospital, nowadays strictly forbidden. And of course, the hairstyle was different that time. So during the 48 years, 8 years since 1973, I have been as a staff member and chairman involved in treatment of more than 70,000 neurosurgical patients and operations. And personal experience was mentioned already, more than 16,000 operations. This includes 6,500 cerebral aneurysms, 600 AVMs, and so on. I have published also on pineal tumors, colloid cyst, and many other subjects, but mainly on vascular cases. So this became my principle: simple, fast, clean, while preserving normal anatomy. I saw only one operative video here, and this is something very special, certainly not many times done. This is a giant basilar tip aneurysm. 68 years old female had compression of the brainstem. I made a subtemporal approach, which I learned by reading the books, publications of Drake and Peerless, and then later by the fellowship by Professor Drake and Peerless. And this is opening the, cutting the tentorium, fixing the tentorium, and now we see the basilar artery. Now we see the broad base from the aneurysm, and now temporary clip is going on the basilar artery. And because it's giant aneurysm, you have to open the aneurysm, otherwise you cannot clip it. And this is, of course, no return place. You cannot say that I regret very much this surgery. So push several clips, change their position. Usually the Drake principle was that when dealing with giant aneurysms, you have to push first a ring clip, fenestrated clip, because it holds and doesn't slip, and then close the fenestration with long clips. So here is also bleeding from the venous bleeding, but mainly bleeding is coming from the retrograde filling of the opened aneurysm. And so finally, after placing, traveling with the clips, we have a good result, taking the first clip out, because you should not have all the base clipped in giant aneurysms, and now taking a long clip to put distally to close the fenestration. And so this is now the situation. taking the temporary clip out. And this is the ICG. Showing and checking with Doppler. And these are postoperative CTs, DSA, perfect clipping of the aneurysm. And these are the CTs showing that there is no perforator injury. So as mentioned, so 2014, 69 most important neurosurgeons in the last 100 years were elected, and I was fortunate to be one of them here in the north part, in an extremely good company, Cushing, Dandy, Yasakil, Drake, and so on. So this was Helsinki. This was extremely small department as compared to many big departments I have visited around the world. We had 50 beds, 16 intensive care beds, and 4 operation rooms in an old building, but it became the pilgrim place during my time for the world neurosurgeons. So, doing surgery, you have to plan, and then doing clean surgery, you are effective, and this is very important. So you can do many cases a day, and you don't need so much operation rooms and beds. And when you are effective, administration loves you and they support you. And one thing is important, fast surgery is cheap because you can do many cases a day. So when I was making my residency, beginning my residency in 1973, in Helsinki, there were 750 operations. When I became chairman, 97, 1,700 operations. And when I left, retired, 3,500 operations. And the hospital stay became 3 times shorter, 4 days average. And this is my successor, Professor Mika Niemelä, in operation room. So my principle has been to use simple microinstruments and short microinstruments because you lessen or increase the accuracy of the tips of your forceps, schizos, bipolars, sucker, and the instruments are short. And of course, when you go deeper, then they must be longer. In China, where you are using chopsticks, and also in Japan, of course, your hands might be more skillful. And here in China, they use very long instruments. I don't see this is a good way to do the most proper neurosurgery. And you are not working alone in the operation room. You need a good team, 6 players on the ice, like in ice hockey. Here, extremely skillful Shrapner Anna-Lena, giving the instruments like a lightning without speaking anything, just looking at the screens, and she knows everything. And this is the same situation. Moved to Zhengzhou, Henan Provincial People's Hospital. Very good scrub nurse, Ping, looking at the screen, and she knows what's happening, and the instruments are coming without any big discussion and without any delays. So research continues. Of course, this has been important. I will come back to that because this is very important. This is extremely important sentence. This is written in the book of Drake Peerless Hernesniemi, vertebral basilar aneurysms, London, Ontario experience on 1,767 patients. This sentence is from there. Every man owes it as a debt to his profession to put on record whatever he has done that might be of use to others. And this is very important. You should publish and write down your experience. So this is, I have followed this as much as possible, more than 600 publications, and as mentioned, this Helsinki book has been translated in very many languages, also in Chinese and Chinese language. So you should study your complications and poor outcomes. Complications are no fate. They are mainly caused by lack of skills and of knowledge. So this is from Xi'an, the terracotta soldiers. When I look at these pictures, I have been also there 2 or 3 times. When I look at these soldiers, I think about my complications. This one died, this one had hemiplegia, this had cranial nerve deficit, and so on. So this is a big number when I have operated more than 16,000 cases, so there is a big army of these complications. And this is wonderful sentence of Dr. Drake. You should think about that. If only we could have back again many of those who were lost or badly hurt for a second chance in the operative room, what we have learned. This is very important sentence. We should analyze our failures especially and share them to become better as a neurosurgical society. We published a lot. When I came to Helsinki, there were 4 publications that year, and then 2010, 54, and when I left, there were close to 100 publications. So this is the number of publications. Age index rather good for a neurosurgeon. I have done all the publications without being on research leave. And this is the last year. We had a good team, fellows, residents who were ready to write. And when we had an idea, so next week, a case report or case series was written down, and it circulated around this Helsinki machine, and we could publish and successfully publish a lot there. About learning, this is the old rule of 10,000 hours. If you train 10,000 hours, you will be at the top of the world. And my rule is that when you have been 10,000 days in operation room, then you are at the highest level of your neurosurgical career. You should read anatomy, learn anatomy. This is the most important thing. I studied in Zurich, and my late anatomy professor, late Giant Tenderi, he was always shouting, medical study is a lifelong study, and anatomy even more. And he was totally right, because you need more than human lifetime to learn all the anatomy. And these are my teachers. Look at this picture. Professor Yasakil, 63 years old here. Professor Drake, 68 years old, and after thousands of operations, they are still studying and learning and enjoying like small boys. This is Chicago, 1988. Training is lifelong. You should learn to use your time, optimize your surroundings, to have enough time for neurosurgery. You should learn from history and surroundings, and you should listen to your teachers, but don't believe everything. Otherwise, you don't make any progress. You should discuss your problems with friends and one mentor, not with everyone, but with somebody you trust. You should work hard, do also unpleasant jobs well, assist a lot in operations, and learn from others, nurses especially, and cooperate well. You cannot become alone a neurosurgeon. You need people around and social behavior. Nowadays, the traveling is banned. It's not so well possible, but I have traveled a lot, around 1,000 times around the world, and also spent a lot of time in cold corners of different operation rooms, 3 years, and observing other surgeries hard, but you learn a lot, and I have taken many good tricks from other operation rooms. This is Zurich 1982, when I went first time to see Professor Yasakil to operate on, and this was a big turn in my life because I saw real microsurgery. He was like Usain Bolt, #1, and then there were no one else that time, and then some people on the third place. So this is the international team sitting after operative day in restaurant because you couldn't discuss anything in the operation room or surroundings. So we discussed the operations after surgeries. One day, this young Mexican neurosurgeon, Jesus, said that one day we will be better, and we didn't believe, but of course younger generations are always getting better. There's a Chinese or Japanese saying, when the student is ready, he will go and find a teacher, and I did that way. At the age of 45, I went to Professor Drake and Peerless to study more, and of course Professor Yasakil was my mentor and hero. So these were my teacher. This is Professor Drake, great, excellent surgeon, good medical doctor, but also good human being. And this is certainly one of the most difficult things to do in your life. You should learn with masters. Here, this is Istanbul 2018, I think, with Professor Yasakil. Professor Yasakil, as mentioned, has been my hero and mentor. And this is Helsinki Life Course. This is late. So Oliveira, present chairman in Helsinki, Mika Niemelä, me, Reza Dasti, my good friend, Ugur Tyre, Ali Chris. So this was a good times in the Helsinki Life courses. Unfortunately, it is finished now. So we are standing on the shoulders of giants, and we continue there. We are not beginning from the same, and that's why you should publish, that we don't make the same errors. So all the time the skills and the experience is growing this way, and we should be grateful for them, always thinking about them when we do our surgery. So this one I showed already. And one important thing, I think you should not be greedy, run after money. You should learn neurosurgery. Certainly in some countries you can be well paid with neurosurgery, but the main thing is to do good surgery and take good care of the patients. About teaching, you should train your best young people. They should become better than you. Professor Drake used to say, if we cannot find that kind of person who is getting better than we, then we wait, and one day he will come. This was his principle. So this is from the operation room in Helsinki. This is the world map and shows the visitors coming to Helsinki. More than 3,000 came around the world. And I have also went most of these places. So bilateral traveling, bilateral learning. And this is my first fellow from China, Hu Shen, and then Japanese, Keisuke Ishii, Turkish, Ayse, Emil Afsi. And this is after operation, we are discussing the surgeries, details of surgery. When the fellow was closing, then I was very open for discussion of the surgeries. And we made many PhDs, more than 30. This is February 8, 2009. Professor Spätzle's opponent to Dr. Martin Lehecka on his thesis on pericallous artery aneurysms. These are very common in Finland, 6% of all in our databases. And here I show in the picture in the operation room, I show my operation on pericallous artery before the PhD examination in the morning. And this is my last fellows, Spanish-speaking group, 2013 or 14. With them, I went to Russia, Moscow, Burdenko Institute, where I became honorary professor. Burdenko Institute here with my very great neurosurgeon, well-respected Professor Konovalov. And some other awards, Madrid, Cajal membership. And what I'm many times asked how to learn nowadays. Nowadays, the learning neurosurgery is easier. Sharing of the experience is by far more easy. Traveling, not possible nowadays, but there are a lot of videos and increased number of publications. Training is better, and there have been many live surgery courses, like I mentioned, in Helsinki 20 times, and then I have been involved in these live courses around the world, also in the Link course in Paris. The live course in Helsinki has finished, and I might be that this is the fate of many of the live courses because of the COVID situation and its aftermath. So I retired in Helsinki 2015 at the age of 68. I wanted to continue my experience, went around the world, Peru, Indonesia, USA, Nepal, and nowadays 3 years in Zhengzhou, China, in the heart of China, Henan Provincial People's Hospital. Like in China here, signing the contract, always very festive happenings in China with music and with videos. I was asking myself when I came to China, can I change something in Henan, China, world? Maybe. I wanted to move to Helsinki and my world to Henan, operative room I could move, but not many other things. China is different. There was a plan to make randomized study of the treatment of cerebral aneurysms. It is not possible here because of the organization is totally different, and there's a follow-up study of the patient is totally different than in Finland, where you have 100% of the follow-up, and here it is extremely low, I would say, below 10%, 5%. So I wanted to take also fellows and visitors around the world, like in Helsinki, but it was not possible. And then the COVID time came, and it is China is closed totally now for visitors. So, but live courses we could arrange, like in Helsinki. We had great surgeons like Vinko Dolens here. This is Victor Hugo from Mexico, and this is Xubin, the champion of the bypasses of the world, more than 8,000 bypasses, and he was the man who brought me actually to China, and is a good friend, and is becoming one of the big world stars now. This is a Shaolin Congress, always in November. A lot of thousands of people in this neurosurgical congress, where we have elected as the We have given the prizes for lifetime work in neurosciences. We gave to Professor Yasakil, we gave to Professor Vinko Dolens, we gave to Professor Guglielmi and Konovalov, and these are the highly respected prizes. So this was Helsinki. There was live course all the time because of the many visitors, 3,000 visitors. We wanted to do the same, only partially successful here. And what I always say here in China, this counts for all the world. To be the highest level of neurosurgeon, you have to have good skills in neurosurgery. You should publish, and to publish in English, you should be good in scientific writing. Otherwise, you remain only local hero. And this is my message. This one I might and hope and I pray I can change in China. They should not shave the beautiful hair like here. Female hair is lost in craniotomies like you see here. I'm not doing that. I have done 3 years without shaving here, but it is not spreading around. I hope that when I'm leaving this country, then they will take this model, because the females are extremely happy when they don't lose the hair in the craniotomies. So thinking back shortly, what would I have done differently? I should have spent more time with family, and I would have liked to spend also more time for neurosurgery, doing more sports, more readings, arts, more traveling, learning of more languages, and doing more bypasses. In which order? This is why I'm showing this slide. It's carpe diem. Life is extremely short. It is like yesterday, June 1st, 1973, when I came in neurosurgery, my first day in neurosurgery. So spend your time well. What's next? Some years more in neurosurgery. I make serious effort to maintain my skills, try to train young people. At the moment it's very difficult, and in China it's very difficult because the communication is difficult, and of course also the attitude seems to be so that the Chinese way is the best way, so you are not loving to learn from elsewhere. And then I want to learn to write. I have written my memories. It will come next year out, and I hope it will be translated also in other languages, main languages of the world. So this was the Helsinki course, one of the most important parts of my neurosurgical life. Icons of neurosurgery. Yasakil was operating in Helsinki. Konovalov came. Dolens was operating there. Almefti, Spätzle, Guglielmi, More, and so on. Everybody came to Helsinki that time. So how to continue? You should be in good health. Neurosurgery is hard contact sport. You have to be in good condition mentally and physically. And this beautiful sentence of Michelangelo: we paint with the brain, not with the hands. And from Dante: you were not made to live like brutes, but to follow virtue and knowledge. And this is certainly neurosurgery. So I thank you very much. Thank you for the time you have given to me.
Thank you very much, Professor Juha, for the wonderful talk. When your life is like an open book for all the young neurosurgeons to learn from. Every lesson, every step, every word you're saying is like a big learning step for us. Thank you very much. Dr. Liu, maybe you can take on.
So can I ask a person, the Yuher?
Of course. Please go ahead.
Can I ask? Yes. Thank you very much for your philosophy, the life, how we should spend a life, a neurosurgical life. Thank you so much. And I want to ask, what is your opinion about the future neurosurgical treatment? Because there's so many endovascular, and also the radiosurgery, and also the minimally invasive. So many has been changed the year by year. So how do you think about how you can estimate the future treatment of the neurosurgery? Please let us know. Thank you.
Now, this is, of course, the question. So, endovascular surgery, radiotherapy, and so on, they are giving hard pressure for good microsurgery. Like I said, if you want to continue in this field, you have to be good and efficient. You have to be both. So you have to be highest level of microsurgery. I think there's a trend now and a group of neurosurgeons who are heavily increasing the skills in microsurgery, and also the follow-ups of some treatments like radiotherapy and endovascular therapy will show that open microneurosurgery is still extremely important place in treatment of our disease, of these diseases we are treating.
So what about the shoring, where you are living now, and the Chinese young doctors? They are they the hybrid neurosurgeon?
This is, of course, for me a very hard place, because this is an extremely strong endovascular center. We have more than 1,200 aneurysms a year. 75% are treated by endovascular means. Also, AVMs are heavily tried to be treated by endovascular means. So it depends. This is huge. So many neurosurgeons and different attitudes and methods, but the endovascular is extremely strong in China. So this is how it is. So what comes to my surgeries? Poor people, because they don't have money for the endovascular therapy. This is how it goes.
But I think that the failure case of the treated by the endovascular, maybe they will come back to you, I think. So so that means the stress to import
the admission policy in China is extremely difficult, because there's some bonus. Those neurosurgeons get some bonus for the treatment of their cases, so they are not willing to share the cases. So what I'm doing here is 150 cases a year. This is okay for me, because I'm slowing down and I've done enough cases in my life, but I could do more. I see every day cases could be done better by microsurgery than by endovascular. This is my opinion.
Thank you. All the best for the future career. Thank you so much.
Something more?
Yeah, Professor Joa, can I ask you a question? Truly amazing lifetime, and I mean, you're still achieving a lot of things. But like what Professor Kato asked you, and since I mean, I also experienced that with my young specialists and residents. What do you think is, how does it go? Because like for you, when you started off, even for myself, when we first started off, we have a lot of cases and a lot of practice. But now the cases are, there are more surgeons, more younger surgeons, so the competition is higher. And so it's difficult for them to actually achieve skills in a short time. Like, if for you, maybe in 5 years, you could have achieved a lot of skills, but now maybe they need to take 10 years or a bit longer because the cases are getting less. So what would be your best advice to someone who really wants to become good at what they do?
You should go to laboratory. You should train there. And then you have beautiful videos nowadays. I never saw anything like that. I was reading in the books how to operate on basilar tip aneurysm, some few figures. So this is how it goes. So you can, if you spend your time with the videos and learn anatomy, you can become by far better than me. This is certainly so. And it is a long way to be a good microneurosurgeon. It is not so that you can be a good microneurosurgeon in few years. Nowadays, it is love of comfort, because with endovascular, you can do in a couple of years, you can do all kind of things, but with microneurosurgery, you cannot do that way. So you have to have persistence and some goal to become a very good microneurosurgeon. You have to be patient with your, this competition between, but the neurosurgery is competition all the time. It has been my life, competition all the time. It is competition in academic neurosurgery, in private neurosurgery. So you are competing about patients or papers or research, so and academic titles. So this is hard fighting all the time.
Thank you, Prof.
That's why you should have some friends. That's why you should have some mentors and friends in neurosurgery. Otherwise, you cannot manage. If you try to be alone, then you cannot manage.
Yes, totally agree, Prof. Totally agree. Thank you.
Professor, may I ask you a question?
Of course.
This is Alberto Feletti from Verona, Italy. Of course, I really appreciate it. Thank you. Thank you. Of course, I appreciated your talk. We are more familiar listening to a different style of presentation by you with many intraoperative videos, and we learned a lot from those videos. But I think today this presentation was as well important, because in my opinion, young neurosurgeons can learn neurosurgery not only from a technical point of view, but also learning from the lifestyle of giants like you. So my question is maybe difficult. My question is, if you could go back in your life, would you change something? I mean, would you do different choices? Would you visit different places? Would you do something different compared to what you have done? What you have done, of course, led you to the top of neurosurgery. But sometimes maybe people think back to their lives and wonder whether they could have done something different, of course, from a professional point of view. So this is my question. Yeah,
I showed my slide where I told that carpe diem, time is short. So 50 years goes very fast. So I achieved more. My goal when I was a resident, my goal was to become a professor, and I could realize that. But what I achieved in Helsinki, bringing the Helsinki one of the top centers in the world, this was by far more than I could think, and in this way I achieved more there. I went to Professor Yasakil, I went to Professor Craig. They were at that times the most #1 cerebrovascular neurosurgeons in the world. I learned a lot from them. Well, I should have visited some other top neurosurgeons in the world to learn more, but I didn't have so much time for that because I was chairman or co-chairman and very heavy in clinical practice, and actually I didn't have so much money to go everywhere. So it was, we are not so well paid in Finland. So it was also a question of money to take care of the family and to travel everywhere. It was not possible. But actually I could do a lot. So I don't regret so many things because I achieved more than in my highest dreams.
Thank you.
I'm, as mentioned, I have written my memory, so I will analyze better and in details that it will come up next year.
I have a question. So there are many countries, especially low resource countries, where the situation and capacity of neurosurgery is substandard. The basic infrastructure itself is not available, including the microscope, instruments, endoscope, or navigation, and even the availability of the lab. As we said, you can go to the lab and train. Even the availability of the lab is also very poor. So for these kind of countries, like today we have a webinar where we're trying to encourage neurosurgery in Afghanistan, Myanmar. So what do you think? What message or what suggestion you want to give that how can we build up the neurosurgery to a better capacity in such kind of countries?
I couldn't hear all the questions, but when I was trained in Helsinki, the level of neurosurgery was not so high. But nowadays, you see good microneurosurgery all around the world. So when the resources are not so good, so the young people, they should learn anatomy. They should learn anatomy. Anatomy you can learn in many different ways. Of course, in a laboratory. If you don't have a laboratory, then other means. Then you read the books, look at the videos, beautiful videos, and this is hard working. It needs time, and time has everybody. If you give the time to learn, it is very hard working, but this can be done if you buy the books or have the videos and you don't work with them, you don't learn any anatomy. So learning anatomy is the most important thing. And then, of course, with being heavily involved in the clinical practice, this is important. So spend your time in operation room. In Europe, working time is 37 hours nowadays, a week nowadays. With this number of hours, you will not become a great neurosurgeon.
Thank you. Thank you very much, Professor. Dr. Liu, you want to say something?
Hello, thanks, Sachin. Professor Zuha, I wish to find out from you, Professor, what's your opinion regarding the term shortcut in neurosurgery? Some are considered safe shortcut where they can save time, shorter surgery, and some, in my opinion, probably are not so appropriate because the principle in neurosurgery that I know, what have been opened might be closed according to the sequences that what we have done when we open. So when we're closing back by right, you should follow all the steps. So what's in your opinion that is there any such thing as shortcut in neurosurgery? Which are those safe shortcut? Which are those should be avoided? Thank you, Professor.
What is shortcut? That you make something, you leave some steps away, or what do you mean?
Yes. For example, like now it's a very common practice that no dura closure in the compressive craniotomy. Just for example, one of the examples of shortcuts.
I don't like shortcuts. I have done clean surgery. With clean surgery, you are doing very fast, but you have to do all the steps. With clean surgery, I could operate from skin to skin, MCA aneurysm in 25 minutes. And this is no shortcut. Every step has been done. So it is nonsense to do all the steps. So if you make shortcuts, then you don't learn. And I don't know if you should. I don't love those hemicraniectomies. They are done in excessive number here in China. So in every case, do you make decompressive hemicraniectomy? I don't love them very much, but it is the way nowadays. So, but shortcuts are not good. You should make painstaking all the steps and clean surgery. This is important.
Thank you, Professor.
Dr. Juha, so please go ahead.
Okay, thank you. Professor Juha, thank you very much for those great words for young neurosurgeons like us. I also would like to ask you, what would be your advice for the first 5 years once you pass your training program for a young neurosurgeon? And what would be the ideal time when they're looking at developing a specialty practice? Because in most of the countries, you'll have to do everything, brain, trauma, and spine. Of course, your heart is going to be elsewhere. So how does one go about that as a young neurosurgeon passionate about a specialty?
I have done always everything. First 5-6 years, you should do everything and get involved in everything. So not to subspecialize too early. I have done more than 1,000 spine and 1,500 spine, a lot of head injuries. Head injuries are the material you learn to do craniotomies, and you should do everything. And first 5-6 years you should be hard working and learn anatomy, or learn anatomy and hard working. Read the beautiful textbooks and look at the videos and follow the internet. You have so much information, good information nowadays teaching. So this should be spent like that. And then of course during these 5-6 years you might find your subspecialty and to do a fellowship, but I think you should try to do everything. This makes you better neurosurgeon. I have done always everything, shunts, hundreds of shunts, and all kind of trepanations and so. So take a look this what is there, and then select a little bit later. Be patient.
So just maybe the last question from the guy from the Afghanistan or the Sri Lanka or Myanmar. Please ask Professor Yuher, because it's the last chance for you, please.
Thank you very much. I'm Dr. Prizat from Afghanistan. Thank you, Professor Kato, Professor Joha, and Sachin. It was very good memory and experience, and we learned a lot of. I got a lot of notes for your experience. Thank you very much. Just I like to know about the HPPH live courses from Masters of Neurosurgery. Is it possible for Afghan neurosurgeons to attend these courses, and when the COVID pandemic finished for live courses?
I think this COVID has major influence on traveling also after COVID. So I think,
yes.
For example, Helsinki, they finished the live course. It's no more working, so it is now finished. And I think Phoenix is continuing, Sapporo is continuing. How is it in Japan, Yoko? We have live courses.
Yes, we have 5 waves now, so still we cannot have it.
Yeah. So this, I think it has a major influence. So this is one of the drawbacks of course of COVID. But what I didn't mention in my lecture, so during this COVID time, these webinars have become common.
Yes.
This is has been extremely important, a good way to transfer the knowledge, and this is very important. So you can come in contact with all the world and see all the specialists and have good discussions in this webinar. So this is wonderful way. This has increased like swamps. Now during the COVID time, I think this will continue. This will stay. And the live courses might go down. This is my thinking, because it needs a lot of traveling and staying. Of course, it is different to be in the live surgery, to see the people in the live situation. But of course, you can transfer also live surgeries by internet. You can transfer, but there is not such a real feeling of blood, sweat, and tears.
Yes.
Like that. So this is the situation now. But we have to manage best, and the webinars have proved to be extremely good way to transfer knowledge and experience.
Okay, thank you. I also mentioned about after COVID, if COVID-19 is finished. I told that
I didn't
after
understand.
COVID. Yes.
I didn't understand your last question.
Okay. Just I mentioned about when the COVID finished. Is it possible to arrange live courses?
In China we can arrange, because in China you can travel, you can make domestic traveling, but not come inside China is difficult because 3 weeks quarantine when you come in here, so you cannot take that.
Okay.
You cannot take that. So it is. I think the same situation is continues and may take a long time. It's my estimate, but my estimate is only my estimate that it may take years that we are back in the situation before COVID.
Thank you.
Any other question from first graduates from Sri Lanka, Moldova? Dr. Alexander is there from Moldova. Anybody from Sri Lanka? Dr. Hemanta, you want to ask anything? Dr. Ahmad?
Yes, I'm here.
Yeah, Dr. Alexander. Please introduce yourself and go ahead and ask us.
Yeah, sure. Dear Professor Yoko Kato, Dr. Juha, panelists and attendings, I'm really thrilled to be a part of your beautiful community. I hope that we can make a good collaboration and give birth to something nice, to something beautiful in neurosurgery. And hope you will be able to see outside of this online environment in offline and do a congress like we usually did. I'm sorry, by the way, I can turn on my camera. I'm a little vacation. I'm right now, but I'm really wanted to join you. Okay, I'll show my face.
You are from Romania, Alexandru?
No, I'm from Moldova. It's between
Moldova.
Romania.
Okay, close to that. Yeah.
And Ukraine.
I've been
Yes.
Moldova. I've been Moldova. Yeah.
Oh, nice. And regarding me, I'm a junior neurosurgery and neuroscientist working in the Institute of Neurosurgery and Neurology Neurosurgery. I think you know Professor Gure Zapuka. More about me.
He has been in Helsinki. Yeah.
Yes, and he told me that he knows you also very well. I have few publications regarding the brain stimulation in Parkinson's disease. I did a 1-year scholarship in Germany, Kiel, where I learned how to do functional neurosurgery. And my actual dream is to pioneer the functional neurosurgery practice in our country to help patients with various movement disorders. Also a member of VSSN, VSSF, ESSFN, ACNS YNS, American Neurosurgery Society, and as for recently a new member of your beautiful young neurosurgery community of the Asian Congress of Neurological Society. And I think that's it.
Yeah, I was doing also stereotaxy 2 years when I was a resident. So I was with Dr. Laitinen. He was at that time world famous neurosurgeon, top stereotactic neurosurgeon. I was 2 years with him. So and nowadays I think this will increase the number of functional neurosurgeries, increasing the specialty. So this is not everything is going down. So functional is, yeah.
Yeah, true. Thank you.
Very much. Is there any question?
There's something wrong. I cannot hear anything, Sachin. What do you say?
Hello, Dr. Liu, maybe you can take over. I think my audio is not there.
Hello, Prof. Thank you for all the discussion, and we hope that we can continue connect with you, and probably because we are engaging more young neurosurgeons from underprivileged countries such as Afghanistan, Myanmar, and recently we just engaged with Sri Lanka, and hopefully more countries will be able to gather the young neurosurgeon and to learn more from Professor. And at the moment, may I share my screen? Just want to introduce something. So we are going to start our new initiative for the young neurosurgeon. We have many requests from a lot of young neurosurgeons and how to join ACNS membership. And this is we're going to bring to our executive board, and where at the moment the ACNS charges for membership is 100 per USD. However, we think that it's too high, especially for low middle income countries. We plan to propose USD 50 for every 2 years. And here are some of the benefits that we're going to offer to our members. And first of all is discounts in publication costs, public professing fees in our AJNS. And this is not limited to number of publication. The more publication you have in a year, the more discount you will get. And also we were thinking, because all this while, most of the books by ACNS are free, but however, there are some that may need some payment in those are not in the open source. We are trying to get some discounts. And also we are thinking to give more opportunity for young surgeons to write small manuscripts which are not to the level of publication in journals, and they are allowed to be appear in our website after being screened by our website coordinator. And hopefully those members will be given more chance to join as a speaker in a young neurosurgeon forums, both virtual and face-to-face meeting, hopefully very soon. And also we have, I think, more than 10 training center, ACNS training center, and then those will be given opportunity. And hopefully we also thinking that we can start on this mentor-mentee program. Hopefully Professor Juha can be part of our mentor that will be able to help us to educate a young neurosurgeon, especially in the region of Asia. And also priority to join any training course. And also we be able to give some recommendation letter to those who want to join in training and fellowship program in any institution affiliated with the ACNS. And for ordinary members, we also are looking at giving them more opportunity to organize a program related to ACNS, invitation as reviewer and editors in AJNS, allowed to use ACNS logo in their official corresponding, and participate in at one of subcommittee in our ACNS, and hopefully they will take the lead for the future direction in ACNS. Also, I would like to take this opportunity to mention that we're going to have a live telecast 2 days seminar on 10 and 11 July. I'm going to send out the flyers for the event, just to show we have a biggest number of participants in our YNS seminar, where we have 24 YNS going to speak in this forum. This is the biggest number that we cater for them, almost half a day for them. And they are from various countries, from Albania, Algeria, Indonesia, Pakistan, United States of America, China. So this is a big forum for young neurosurgeons. We hopefully we be able to organize this more often, and hope to get your participation in the future. We may organize a next seminar for young neurosurgeon on web-based in November. I think it's 20th and 21st November. Those interested, please give your name and contact to Dr. Sachin. Hopefully we can communicate with you soon. And you can see all this flyer ready soon. That's all I want to show today. Thank you.
Thank you.
Should I introduce our
with the next talk? Unfortunately, Dr. Sarachan. So, Dr. Liu will introduce our next speaker.
Thank you, Sachin. I would like to introduce our next speaker, Professor Alberto Felitti. As he mentioned earlier, he is from the University of Verona in Italy. He is one of the young neurosurgeons and currently the president of our Fujita Head University Bantane Hospital alumni president, and he carry a lot of activities. His main interest is in endoscopic ventricular surgery. When I look back at his CV, he's a very active neurosurgeon, and I think and he has started publishing since 2005. And what and he have more than 60 publications now at his young age as a professor. And he, what I observed in his publication, he must always be a first author in all publications, at least once a year. I think this is a very good example for us to follow. And I think he have more than 500 citations, probably very far to catch up for, as per shown by Professor Juha. But we hope that we can learn something from his talk today. Let us welcome Professor Alberto Felitti. Thank you.
Thank you very much, Liu, for this too nice presentation and introduction. I have been asked to share with you my experience about ventricular endoscopy, which is actually one of my interests besides vascular and oncology. I think endoscopy, ventricular endoscopy is like probably a small niche, but indications for endoscopy are surely increasing in our daily practice. Today, I would like to show you a specific surgery, endoscopic surgery in the ventricles, which is the aspiration of intraventricular hemorrhage. I mean the aspiration of blood from all 4 ventricles. We all know that intraventricular hemorrhage carries a very high mortality. In some series, this mortality rate is up to 80%. These are really huge and sad numbers for our patients. And we also know from previous studies that there is a relation between the volume of blood in the ventricles and the outcome of our patients. A volume larger than 20 milliliters of blood in the ventricles in patients with subarachnoid hemorrhage is actually lethal, as shown from previous studies. And why blood in the ventricles is such a bad prognostic indicator? Because blood can give a chemical damage, but it also increases intracranial pressure, of course. And besides that, it can lead to obstructive hydrocephalus. And for all these reasons, there is a need to reduce the mass effect caused by blood. And we need to do this reduction as fast as possible, of course. There are several different ways to manage this condition. Some of them are really invasive. Of course, I'm talking about craniotomy, which has been proposed in the past years, but I think probably nowadays it is not the best way to approach this problem. And others are minimally invasive. The most common, of course, is EVD, external ventricular drainage, that can be paired with fibrinolysis. And another way is endoscopy, and this is the topic we are going to talk about today. External ventricular drainage is the most common treatment in this kind of patients. It is a very fast and simple operation. It can help resolve the acute hydrocephalus immediately, but this method has also some drawbacks. Very often it needs to be bilateral because it can frequently get obstructed by blood clots, And still we need to wait a long time before we can see blood clots getting more fluid and be washed out from EVD. So this implies a longer hospital stay and also an increase of complications. Think, for example, about the risk of infections. We can speed up this lysis process using fibrinolytic therapy. This therapy, intrathecal therapy with urokinase, for example, has been shown to speed up the resolution of intraventricular blood clots compared with EVD alone. But still, we need to wait several days to see these results. And nevertheless, the risk of infection is still high in these cases. The alternative is endoscopy. This is a preoperative CT scan of a patient with IVH. You see it's a tetraventricular hemorrhage. And after endoscopic treatment, we can get rid of blood not only from the lateral ventricles, but also from the third ventricle and from the fourth ventricle. This is an early postoperative CT scan. We know from previously published papers that with this technique, we can not only reduce mortality in this specific set of patients, but also we can improve the outcome and we can reduce the VP shunt rate. And in particular, this study showed that based on different etiologies of intraventricular hemorrhage, the use of endoscopy compared to external ventricular drainage alone can reduce the VP shunt rate for these patients. You see, VP shunt patients are marked in dark color in these histograms. This group is the group of patients treated with endoscopy, and this group is the group of patients treated with EVD alone. And you can see that actually VP shunt can be reduced. How can we obtain these results? Of course, you can use rigid endoscopes, but with a rigid endoscope, you have a limitation of movements inside the very complex and irregular geometry of the ventricular system. And you can get rid of blood from the third ventricle, but for sure you cannot enter the fourth ventricle. And entering the fourth ventricle in these patients and aspirate blood from the fourth ventricle is extremely important, because it has been shown that the blockage, the obstruction of the fourth ventricle by blood is a very, very bad prognostic factor for these patients. And the only way to reach the fourth ventricle is to use flexible scope. You can see flexible scopes are very versatile. And in this kind of operations, we use the operative channel of the endoscope as a sucker to aspirate blood clots. The instrumentation is very simple. Besides the flexible scope, we use a three-way tap, which is used to connect to the endoscope, both an irrigation system and a syringe to do the aspirations. Of course, before starting this kind of surgery, you must know very well the intraventricular anatomy. We have a very good experience in intraventricular endoscopy with actually, now we have more than 800 procedures performed. Here you can see a very familiar anatomy with the floor of the lateral ventricle. Here we are entering the Monro foramen. We can see the third ventricle, the floor of the third ventricle. we are all familiar with this kind of anatomy. Maybe we are less familiar with the anatomy of the posterior third ventricle, which is a very interesting anatomy. I recently described this anatomy and its variation in a recent publication. And you can, in some cases, not only inspect the anatomy. This is the abenular commissure. This is the roof of the third ventricle with the internal cerebral veins. This is the pineal recess. This is the posterior commissure. But in some cases, you can even navigate the cerebral aqueduct. It is actually possible if the aqueduct is not stenotic, and you can finally enter the fourth ventricle. These are the choroidal plexus of the fourth ventricle with the Luschka foramen, and here the Magendie foramen. For intraventricular hemorrhage aspiration, the access point is extremely important. It has not to be too lateral, because if it is too lateral, you will have problems in entering and navigating the cerebral aqueduct. So it must be about 1.5 centimeters from the midline. We use a pilloway, and we insert it into the frontal horn of the lateral ventricle, and through the pilloway, we insert the flexible scope. There are two basic maneuvers for this operation: irrigation, which is used to unveil anatomical landmarks, and also to balance aspirated blood clots, especially when you are in the fourth ventricle. When you are in the fourth ventricle, actually, the endoscope obstructs the cerebral aqueduct. So if you don't balance very well irrigation with aspiration, you might cause bradycardia. So this is very important to know. And the other maneuver is aspiration, of course, to remove blood clots. With these videos, I will show you the surgical phases of this surgery. Initially, this is the entry point in the lateral ventricle. Initially, this surgery can be very frustrating because you can see only red or dark screen because of blood clots. You don't have to be discouraged. You have to be very patient and do aspirations when you see red, and stop aspirations when you see white, because white is the ependyma. So you don't want to damage the ependyma. Finally, you can start seeing some landmarks, like the interface between blood clots and the ependymal layer. And you keep alternating aspirations and irrigations until other landmarks can be visualized. Usually, the first landmark is the choroidal plexus, this one, on the floor of the lateral ventricle. When you see the choroidal plexus, you just have to follow the plexus to the backwards to remove blood from the lateral ventricle. And also you can follow the choroidal plexus forwards. This is the back of the lateral ventricle. Let's see if we can move on. And then you can follow the choroidal plexus forward, and this will lead to the foramen of Monro. Here, choroidal plexus, and this is the foramen of Monro, which is obstructed by blood clots. You can keep aspirating blood clots from the foramen of Monro, and suddenly the anatomy of the floor of the third ventricle will appear to your eyes, like among the fog. Here, the mammillary bodies and the tuber cinereum in front of mammillary bodies. Here you can see the infundibulum and the optic chiasm with the lamina terminalis here. And after getting rid of blood from the anterior third ventricle, you have to bend the tip of the scope backwards. And aspirate the blood clots from the posterior third ventricle until you see the adytum of the cerebral aqueduct. You keep aspirating blood clots, and finally a better view of the adytum can be obtained with the posterior commissure, pineal recess, this one, abenular commissure, and this is the roof of the third ventricle. After that, you can navigate the cerebral aqueduct. Here you can see the cerebral aqueduct is still obstructed by clots from the fourth ventricle. So very carefully, you can insert the scope in the cerebral aqueduct, enter the fourth ventricle, and aspirate blood clots from the fourth ventricle until you see the choroid plexus of the fourth ventricle, another important landmark, and also the floor of the fourth ventricle, which is the brainstem, of course. And if you move the endoscope forward, you will reach the calamus scriptorius. You can see the pica here, the Luschka foramen, the left Luschka foramen, here the Magendie foramen, which can be, of course, unblocked using further aspirations. Here the two picas and the Magendie foramen, which can be set free of blood completely. You can also see the cisterna magna, which is now very open. Okay, this is the final view of the fourth ventricle without blood clots inside. And the results are really nice, especially because you can restore the patency of the ventricular system. Like in these cases, you can see blood obstructing the third, the fourth ventricle. Here, no blood in the ventricles anymore. This technique can be coupled to other kind of interventions. For example, in cases of brain aneurysms, which are coiled, you can do coiling, and immediately after coiling, you can do endoscopy. Like in this case, with a pericallosal artery, ruptured pericallosal artery aneurysm, coiling was performed, and immediately after coiling, endoscopy was also performed, and we could decrease the intracranial hypertension of this patient immediately. At the same way, this basilar artery aneurysm was managed, so coiling of the basilar artery aneurysm, and then endoscopy immediately. And here you can see clearly how much benefit you can do to the posterior fossa of this patient. Similarly, you can use endoscopy after clipping. Of course, after clipping, during clipping, you can aspirate some blood clots, but it's very difficult to set all the ventricles free of blood. We noticed that we can have also a not bad outcome performing this kind of surgery after clipping. For example, in this case, we had a left MCA ruptured aneurysm. I clipped the aneurysm of this patient, but still blood clots were obstructing especially the third and the fourth ventricles. And so I immediately operated this patient with endoscopy, and you can see the blood was completely removed and immediately removed. So a very few take-home messages. I think flexible endoscopy can allow a quick restoration of CSF pathways and can help to decrease the intracranial hypertension of IVH patients. It is a minimally invasive surgery for sure. And there are many evidences nowadays saying that with this technique, we can reduce the frequency of not only EVD obstruction and replacement, but also of the need for VP shunt to these patients. Thank you very much for your attention.
Thank you, Albels. Very good presentation. So can I ask one thing? Can you hear?
Sure. Yeah, sure.
Yeah. Yeah. So when you immediately after the coiling, you use endoscopic evacuation with cloth. That is a great idea, I think. And what about the anti-plated, anticoagulant? How you can use for those cases?
Yeah. It's actually a good question. I think anticoagulant and anti-aggregation drugs can be a risk for this kind of surgery. Actually, this is a exclusion criteria we have for this kind of surgery. But if it is, if an aneurysm is just coiled without the use of stenting, for example, so the patients are not under anticoagulants, so we can do this kind of surgery immediately. Of course, I would be very careful in operating patients who are taking antiplatelet or anticoagulant drugs, because this can be a risk, and I wouldn't do that in such kind of patients.
Thank you. Sharon?
Yeah, I have a question, Bertod. After the washout with the endoscopy, do you put in and do you keep the EVD or do you remove it immediately?
Yeah, this is a very good question. I didn't mention. I always leave EVD in place because it's like a safety procedure. Usually, in really most of my cases, I leave the EVD and I leave it either open but very high, like 15-20 centimeters from tragus, or I leave it closed and I open it only if needed, based on CT scan, if ventricular size increases. But in most of cases, I am able to remove EVD in a couple of days, because in most of cases, the CSF pathway is completely restored. So the patient has no need for EVD. But I always initially leave the EVD just for emergency.
Any other question? Dr. Fahd from Morocco? Do you have any question to Dr. Albelt? Or maybe YNS from Myanmar?
I have a question.
Yeah, please.
Yes, thank you very much for that interesting presentation. Actually, in Sri Lanka, we have only few endoscopy stations around the country, around 2 or 3. So I have never seen this much of this kind of procedure have been done ever. So thank you for the lovely presentation. My question is, if you find ongoing bleeding during the procedure, what are the things you can do? Just for interest sake.
Yeah. Well, if you find a bleeding source, the most common maneuver is do irrigation. Just do irrigation with lactate ringer and be patient. Don't worry. You need to point with the tip of the scope to point exactly on the bleeding source and keep irrigate. In, I would say, more than 90%, 95% of cases, these bleedings are small bleedings, and with irrigation, you can block those kind of bleedings. In my experience, I had a very few cases when after maybe half an hour, 40 minutes of irrigation, there was still bleeding. So I am patient, but not so too much patient. So after 30 or 40 minutes, I decided to change my technique. So sometimes I use the Fogarty balloon, and I inflated the balloon just to compress the bleeding source for some minutes, and this was enough in those cases. In one case, this was not enough, so I pushed some Flosil. I don't know if you use in your daily practice this hemostatic gel through the working channel of the scope. This Flosil came out from the tip of the scope while I was directly pointing the bleeding source. And using this technique plus compression, I was able to block the bleeding. This was needed only in one case in my memory, but most of the time, just irrigation is enough to block the bleeding.
Right. Thank you very much. That's
Thank
interesting.
You. Thank you.
Am I audible clearly?
Yes.
Yes, very good. Very nice. We can hear.
Yeah. So just to add on to those, to that point, though I don't have as large a learning it, but there are two manuals which we follow at our institute. One is we don't use Flosil intraventricularly, because Flosil, it's like a small bubbles, and if they go into cerebral aqueduct, then they can block and we can cause create a hydrocephalus. So we don't use Flosil. One thing, whenever there is a acute bleed which you are not able to stop with the ringer lactate irrigation, we use cold ringer lactate irrigation. And even after 15 minutes, 20 minutes, you're not able to stop. We change our endoscope from flexible endoscope to a multi-channel rigid endoscope. So through which you can pass your bipolar, or you can sometimes even pass your some hemostat like a Surgicel or Fibrillar, but generally we don't use Flosil. In only one case, we were not able to do anything, and then we had taken the patient to the cath lab where endovascular, we specifically identified the source of the vessel, which is causing the blood, and we analyzed that. So just wanted to mention that as an add-on.
Thank you very much.
Thank you, Sachin. Yes, very interesting comments, I think. Yeah. And I agree with you with Flosil, but in that case, as I said, it was just one case, emergency case, and we really didn't know how to manage the bleeding. But I agree with you, it's better to avoid. Actually, irrigation or compression are enough in most of cases.
May I ask a question, Dr. Alberto?
Yes, sure.
Yeah, so I would like to know your thoughts on the use of urokinase. Suppose endoscopy is not available and you will have to just put in an EVD. And in that case, what was your earlier experience before you switched on to this endoscopic evacuation? Did you try with urokinase?
I remember we used urokinase when I was a resident, so a few years ago. But at that time, we were introducing the flexible endoscope. So my direct experience is very low for urokinase. But I remember when I was a young resident, urokinase is effective, actually. But it has some problems. First, you still need to leave an EVD for many days in these patients. Second, you have to introduce urokinase through the EVD. Both of these can increase the infection rates in our patients. Actually, I still remember some patients with very bad ventriculitis after urokinase. Moreover, there are some papers talking about the risk of rebleeding when you use urokinase. I don't have memory of any of our patients who had rebleeding after urokinase, but there are several papers reporting this event. So we abandoned urokinase several years ago for these reasons, and also because we noticed that we could give a larger benefit to our patients with endoscopy.
True, thank you.
Sure. Actually, I have a question for all of you guys, and the question is: Do you have endoscope in your institutions? In particular, do you have flexible endoscopes in your institution? Because in Europe, rigid endoscopy is much more common in neurosurgery. We are very few neurosurgeons using flexible scope in my country. I feel that in countries like Japan, flexible scope is much more common, much more used. So I wonder if there is some of you who has experience with flexible endoscopy.
We still use the rigid scope at the place where I work, and even in the earlier places where I used to work. So the transition from rigid to flexible is yet to happen. But that's not the case in all the centers. In India, there are several places where they use flexible endoscope.
In Malaysia, we only use a rigid endoscope. We don't have flexible endoscope. So we're not used to it.
You are more European.
Yeah, I guess so.
So see what happens in India in the government hospital and the private hospital, I'm sure in the other countries also. The problem with buying a new instrument is the organization will question you, will you be able to give us or create that many numbers? So this kind of instrument you're going to use it very rarely, maybe once in a year, twice a year. You won't get this kind of patient very often. So the another way is the companies like Calzines and Oscolab, they give you the instrument on rent. So they have it on the rent. So if you have a good rapport with them, talk to them, they will give you on the rent. They will charge some amount for those instruments and they will make you available. So for a few cases, we have availed it on the rent. So Dr. Rihanna is there from Afghanistan. She wanted to ask a question. Dr. Rihanna?
Hello?
Yeah.
Can you hear me?
Yes.
Hello and Assalamu alaikum, first of all, to everyone. First of all, I would like to thank the Asian Congress of Neurosurgical Surgeons and also Neurosurgical Society of Afghanistan for this opportunity, and also Dr. Sachin and Professor Kato for this opportunity. Thank you very much. I would like to ask Dr. Alberto, in countries such as Afghanistan, we don't have endoscope, we don't perform endoscopic ventriculostomy because we don't have an endoscope. So we use external ventricular drainage. I would like to ask, as you mentioned, EVD should be done bilaterally, but in patients who have unilateral bleeding in one of lateral ventricles or one side of lateral ventricle, still should it be done bilaterally or only on the ventricle which has the bleeding, or the contralateral side of the ventricle? Just wanted to ask this.
I think in those cases, just unilateral EVD is nice, is enough. I mentioned about bilateral EVD only because in my experience, a number of patients have a tetraventricular hemorrhage. So we start always with just one EVD, unilateral. But very often in those cases, the EVD becomes obstructed. So we have to place a second one, although we want to avoid, but we need to place a second one. at least we used to place before endoscopy entered in our clinical practice. But in cases of a patient with blood only obstructing single lateral ventricle, only unilateral EVD is enough. Absolutely.
Which with the ventricle which has bleeding, should the EVD be inserted, or no, the other ventricle?
Good question. I think that you can have different answers based on the surgeon. In my opinion, if you place the EVD in the obstructed ventricle, there are much higher chances that the EVD will not function.
Mm-hmm. So
before the introduction of flexible endoscopy in our center, we used to place EVD in the contralateral free ventricle. But nowadays, as I mentioned, we don't have this problem anymore, because in those cases, even with unilateral ventricular bleeding, I insert the endoscope in that ventricle, in the obstructed ventricle. I aspirate blood from that ventricle and I leave EVD. But if you don't have the scope, I would place EVD in the contralateral ventricle, my opinion.
Yeah, I think I would agree with Alberto too, because Rayana, you are treating the in a case where you're only putting an EVD and you don't have an endoscope, your treatment is for the hydrocephalus, not for the bleeding. So I think put it into the side that's not having any blood. Yeah.
Right.
So you're treating the hydrocephalus. Yeah.
Thank you so much.
Okay, so thank you for joining tonight.
Thank you for the invitation. It was a real pleasure.
No,
thank
just
you,
Albert,
Rihanna, for participating. Yes.
Okay. Should we have a seat?
No.
So who is the next presenter? The YNS. Sachin?
Yeah, so we're going to have two cases. We're going to have two cases, one from Afghanistan and one from Myanmar. So we'll go ahead with the case presentation now. If we have any further question, we can take after the cases. Is that okay, Dr. Liu? Am I audible?
Yes, Sachin. Yes.
Yes. So we'll go ahead with the case presentation now. So today we'll start with the Afghanistan case first. We have Dr. Hamid Shir Shinwari, who's going to have a case presentation on hydatid disease of the spine. So hydatid disease of the brain is quite known in psychiatry. Hydatid disease of the spine is a quite rare thing to happen, and only few case reports are there. So we're going to have a case presentation from Afghanistan. So can you share your screen, Dr. Shinwari?
Hello, Dr. Sachin. Dr. Shinwari has a problem with connection to Zoom. Unfortunately, he tried the best. He also do some things, but if we go with Myanmar and then sorry for this.
No problem. So Dr. Su, maybe you can start your case presentation. Dr. Su is going to present the case of foramen magnum meningioma. So please go ahead, share your screen, Dr. Su.
Yeah, thank you for kind introduction. I will share my screen. Please wait a minute. Can you see me well? Can you see my screen well, and can you hear me well? Hello?
Yes.
Yes.
Okay. Okay, first of all, I'd like to appreciate you all, Professor Kato and everyone who organizing this webinar and helping us in this very difficult situation, and my mentors, Dr. Cherok and Dr. Professor Chilan for having me here. I'm going to share a little bit about how formal meningioma managed in Myanmar. As you all know, formal meningioma surgery are very challenging for us because of its complex anatomy and quite close to the vertebral artery and lower cranial nerve. Let me express my sincere gratitude to our great mentor, Professor Cherok from Henry Ford Hospital, United States, who helped us a lot since 2013 to upgrade Myanmar Neurosurgical Society and who taught us a lot how to operate for meningioma and many operations. He's very fantastic. He visited Myanmar annually and bring his team once or twice per year, stay a couple of weeks by collaborating scientific operations, teaching us in his free time and organize international seminar and education course, including the remarkable first Southeast Asian Neurosurgical Bootcamp outside the US in 2017 and 2019. He also received the Humanitarian Award from the ACNS for his global outreach, help, and other national first injury award for his work of brain injury in Myanmar with us. It is very great honor for me to see him here as a panelist and giving his time for us. Let me show you some cases. And first, here is the patient is the 38-year-old lady with 3-month pregnancy presenting with a quadriplegic for 2 months. And her neurological examination revealed hyperreflexia with the MRC grade 4.5 of her limb. These brain MRI demonstrate that dura-based homogeneous enhancing extra-Asian met in anterolateral foramen magnum with significant mass effect in the brainstem and upper cervical pulse. So we decided to operate in far lateral approach. Here is the patient position in 3/4 prone position and head is with the 3-pin head holder. And we avoid the excessive retraction of the shoulder. Previously, we used the C-shape skin injection at the right side of the head and also make the transverse sinus and other marker. After the session of the muscular flat and identifying the vertebral artery and pieces around them, sometimes we confirm with the Doppler ultrasound, then suboccipital craniotomy and drilling of the lateral transcondylar parts of the foramen magnum was performed. Sometimes we also perform the lateral mass of the C1 was identified where C1 laminotomy was also done to facilitate the surgical corridor. Dura was open in C-shape section and tracked up to the lateral side, and our microscope foramen magnum system was open to release the cerebellum, and then tumor capsule was identified. And electron position was performed safely and preserved the surrounding neurovascular structure. Central debugging of the tumor was performed by PC version. And remove the upper part of the tumor all the way up to expose the cranial nerve and circular, then expose the lower cranial nerve, and sometimes we cover with the cotton knife. Afterward, rolling up the tumor capsule down and continue debugging on the tumor and lower part of the tumor, attachment of the tumor, base were coagulated and dissected together, some grade 2. And with this thoroughly circular, Dura was glued back in a water dissection. Histopathological research will be the presence of the transitional type meningioma consistent with the WHO grade 1. Post-operative period was unremarkable apart from the need of substitute feeding was needed for 9 policy for 2 weeks and discharged from the hospital in wheelchair for my quadriplegic. Also, MRI research showed gross total recession of the tumor. She slowly recovered from her follow-up and can walk without support and also deliver her child successfully. Another patient was the 41-year-old lady presented with the progressive winner MS lab. At neurological examination, she exhibited mild quadriplegia. Those MRI imaging revealed the presence of right introlateral tumor former magnet, hypointense on T1 and hyperintense on T2 with homogeneous enhancement after contrast in those such as Asia and corneal view. After planning the surgical procedure, tumor was resected by using far lateral step-procedural approach as usual. You can see here step-by-step in this intraoperative photo as usual. We achieved cross-total tumor resection. Some grade 2 was also achieved. Biopsy result revealed meningothelial meningioma. After surgery, in immediate post-operative period show result the lower cranial nerve with mesogastric feeding was needed and weakness of the left side was present. The patient symptoms were resolved on follow-up and can walk without support on less follow-up. Post-operative MRI revealed that low residual mass and released brainstem compression. And the last case is the 48-year-old lady with chronic neck pain, headache, and neck stiffness with a weakness of upper limb followed by lower limb weakness. Thorough neurological examination show hyperaphasia and dystonia. Here, MRI demonstrate the presence of the tumor based on the dura and the lateral portion of the former magnet, which was suggestive of meningioma, compressed the brainstem and upper cervical bag. Here is the patient position, and we use the hockey stick incision later. And now we can use, now we can see here the entire operative photos step-by-step tumor resection with bilateral transcontinental approach. Cross-total tumor resection was achieved.
Dr. Su, you're not audible. Can you unmute yourself? Dr. Su? Dr. Su? Hello, Dr. Su? Yeah, now you're audible. Yeah.
Sorry about that. Yes. Can you hear me well?
Yeah, we can hear you now.
Yeah. Sorry about that. The post-operative condition was an eventful. She was discharged in a wheelchair and less follow-up, she can walk without support. In conclusion, although having very limited resources, we would like to get our patient best quality of life and best outcome as much as we can. Let me express my great appreciation to you all for being together with the people of Myanmar through this hard time. Thank you for kind attention. Pardon me for I can show you intraoperative video.
No problem. Still, those were interesting cases which you had shown. Maybe we'll take another case presentation from Afghanistan quickly and then go ahead with the discussion part. So, Dr. Pirzad, is Dr. Shimari ready?
Sorry, sir. He will try to connect, but have some problems, you know, but like another problems, that's the internet and the connection also difficult in Afghanistan. Sorry for that. He tried. Could you also try yourself, please?
I have to see him. I cannot see him. Only
No, he can't connect. Not connect. excuse me, sir, if it's possible, that's the next webinar he will present his case, because okay, he tried many times, and the links you send and also the links of this webinar I sent by email, but some problems happened, and unfortunately he can't connect. Sorry for that.
No problem. I will do it next time. No problem.
Next time.
Okay.
Thank you.
Yes. Yes.
Okay.
So any question for the case which Dr. Su has presented? Anybody in the audience wants to ask anything?
It was very nice operation and successful achievement. Congratulations. Thank you.
Maybe Dr. Su, maybe the next time, maybe you can make some short video, please. Try to make video. It's easier for understand. Yeah. Yes. It was wonderful talk. Thank you. Thank you very much. Yeah. Sharon, any question to her?
Yeah. Srimat, are you interested in doing base of skull surgeries or surgeries of the foramen magnum? Do you enjoy those surgeries?
Yes.
Yes. Okay. So
yes.
All right. So usually are your patients always in a lateral position when you do these cases?
Yeah, we always use that for my magnum tumor.
Okay, and you
especially
especially in
the anterolateral mass.
Yes, correct. Okay, all right. Okay, do the patients
lateral or prone position?
Do lateral.
Lateral?
3/4 prone. Yeah, 3/4 prone.
3/4 prone.
So let's say, can I talk something?
Yes, Professor, go ahead.
So let's say the tumor is in the anterolateral positions. Lateral position is better. Let's say the tumor occupies the posterior part of the spinal cord, that the prone position is better, I think. So I'm not going to talk about the first case. First case is a paraplegic for the 6 months, but paraplegic for the nearly 6 months, but at the time, accidentally, she was pregnant for the more than 3 months. He came to me at the second trimester. So whatever, maybe he is now paraplegic, so unable to move. So I have to take risk to operate these tumors. So luckily, this is my first case after the Jack Rock. My mentor Jack Rock taught me to do surgery. We are working together happily, and I try to see how he tackled the tumors. So I can do more and more cases, and my younger generations are very happy to work in the skull-based surgeries more and more now. Thank you.
Actually, Dr. Kia Yang, I wanted to ask your young trainee, does she, because the patient outcome is sometimes quite poor, like you said, was paraplegic, does that make her disheartened to do neurosurgery? That was what I was going to ask her.
So neurosurgery is always challenging.
Yes.
So they are actually, we can do the very fine works during the operations, but there might be some complications in the post-operative periods, and so we might be depressed, but we try to be happy with my good results before, and then try to make it as much as we can.
Yes.
Thank you.
Can I ask a question?
Yeah.
Can I ask a question?
Yeah.
Yeah, I would like to know, I didn't get if you use intraoperative neuromonitoring or not.
So actually, we don't have neurophysiological monitoring at that moment.
Okay, do you plan to introduce in the future?
So in the end of 2019, Dr. Jack Rock introduced the neurophysiological monitoring with the Medtronic, and and the Medtronic donated as a cranial monitoring. That is very good.
Thank you.
I think Alberto, I think they, it's not very cheap to use this intra-op monitoring.
Of course,
So maybe, yeah, I think that would be one of the obstacles they would have to face in Myanmar, right?
Yeah, and also I think you need a well-trained person who knows how to use. So it's an economical problem, but also a training problem. So actually, that's the reason of my question. So if there is any plan to improve from this side, because surgical results were very good. I saw very nice post-operative MRI, very good operative skills. But of course, these are extremely challenging tumors and locations. So I was wondering whether there is any plan to introduce also this kind of monitoring, which I think are very important, not only for the patient, but also for the surgeon.
Yeah, after 2019, we can use the intraoperative monitoring in vestibular schwannoma cases a lot because of Dr. Jadrov. Let me hear some comment from Dr. Jadrov.
Yeah.
Dr. Chakrath, you can go ahead.
Yeah.
You're not audible. You're not audible.
Yeah.
So maybe Dr. Albelt, just you can mention about how the usefulness of the pure endoscopic procedure, not only for the foramen magnum lesion, but also the skull base, the tumor. Recently, the more and more endoscopic procedure is better results, such as the craniopharyngioma or colloid cell, etc.
Yeah, for sure. For some skull-based locations, nowadays endoscopy is extremely used worldwide with wonderful results, as you mentioned, especially for the anterior skull base. Indications extended a lot. Also in my institution, we are moving from a microsurgery to an endoscopic management of those kind of tumors. For posterior fossa, I think it can be more challenging. I think endoscopy is extremely useful if paired with microsurgery, even for cases of vestibular schwannomas. I perform a microsurgical removal, but I always inspect the internal meatus with a rigid endoscope. In some cases, you can avoid the drilling of the internal acoustic meatus using a rigid scope. So I think indications for endoscopy are increasing also for skull base, for sure.
In Japan, we have the more and more the getting popular about the tubular surgery. The tubular surgery is, of course, the kind of the endoscopic surgery, but we use such a tube, especially for the posterior fossa or the supracerebral approach. Even the supracerebral approach, I think it's very minimally invasive, I think, for the patients. The shorter operation time and also the less invasive, just a 2-3 centimeter, the incision, and the good faster recovery of the patient, I think. So for the YNS, the doctors, you should learn how to handle the endoscope in the future, I think. So maybe Dr. Albelt can teach you, I think, from beginning to the end, the endoscopic surgery. Albert,
no. I'm still learning. I'm still learning. I should learn from masters. Yeah, and we had really great masters even in these ACNS webinars in the past. So I think we should make more efforts to learn this kind of surgery, because as you said, it's really the future for neurosurgery. Yeah.
Because endoscopy is very high illumination, magnification, and resolution from the bone window. So the tube, the endoscope tube, can reach the region itself. So that's a big difference.
Yes, it's like having your eyes exactly in front of the problem, not outside the bone window. Yeah.
So I wanted to ask Professor Kato. So there are some companies from Japan, like one company I know, this company's name is Kedlex. They make these models for endoscopy training, the models of ventricle, so where you can pass your endoscope and remove the blood. They will put some jelly inside, the models for the endoscopic endonasal surgeries. These models are quite cheap from Japanese companies. So maybe after COVID, once the situation opened, for the countries like one of the YNS from Sri Lanka was asking that they don't have endoscope facility there, we should provide them some training, some hands-on with this kind of models. What do you think?
Yes, in Japan, so many the companies, they are competing. So one big company is Ono industrial company. They make so many models for the endoscopic procedure. Or sometimes the subarachnoid hemorrhage, which is the premature rupture. So we can have a lot of experience with model, I think. So maybe as ACNS, we can have such kind of model.
Yes.
I think it's a good training for the YNS, I think.
Yes. So Dr. Pizzat was asking that Dr. Shinwari, the case from the Afghanistan is ready. We will take the case now, or we'll do it next time. What do you say, Professor Yogato?
Yes, maybe it's next time, I think.
Yes.
Next time we can, we can ask one guy from Ono company that he can show us all the procedure. Yes, he can bring some models in front of you, I think.
Sure, we can do that. So, Professor Pizzat, maybe in view of a time, we can do the case next time. We are already 3 hours, 2.5 hours, we are doing the webinar. So maybe next time we can do the case presentation. You are muted, Professor Pizzat.
Okay, thank you. Okay, sorry.
Yes. Maybe Dr. Sharon or Dr. Alberto can say some final remarks.
Maybe I'll go first and then Alberto, right?
Yes, sure. Women first.
A very great, very good session. I think one thing we need to motivate the young neurosurgeons. It is a very great platform. We should get the lower middle income countries to come in and present cases, because I think sometimes we fail to realize that even though they are lower middle income countries, but I think they get cases that maybe sometimes in the developed countries we might not be seeing so much anymore. So we can learn something from them, and we can also learn from how they advance, like through all the hardships they have to go through. So thank you very much. This was a great session. Thanks.
Yes, I also want to join Dr. Sharon with these greetings. I think today was a great day because, as I mentioned before, during Professor Ernest Niemi talk, we had a master for sure of neurosurgery today, and we could enjoy his talk. It was a different talk compared to other talks by him, but still not less important, because for young neurosurgeons, learning neurosurgical techniques, of course, is important, but we can learn to be great neurosurgeons, not only by technical skills, but also by lifestyle. Professor Ernest Niemi taught us to be committed to our work, to always study, especially anatomy, to travel if possible, or at least to assist to surgeries performed by other surgeons, because we always have to have something to learn. And these messages are very important for young neurosurgeons. And I also enjoyed very much the talk by Sumiat from Myanmar, because we could see that difficult surgeries can be done also in low-income countries if there is commitment, if there is the willing to learn from others and to practice a lot. And I think these kind of webinars that Sachin is organizing on behalf of ACNS are important, especially for those young neurosurgeons who want not only to learn, but also want to try to present their work. This is a very good first step to be trained in presentation, and this is very important if you want other people abroad to know what you are doing in your country. So thank you very much.
Thank you very much, Dr. Sharon and Dr. Abdo. Dr. Liu, you want to say anything to us?
Just want to add on the one the Professor Kato mentioned about Mr. Onu, who have some surgical model. We even have a discussion with Prof. Adiba, who wanted to do some live demonstration hands-on on those models. I do not know how far she had gone. If we could also invite her, Professor Adiba, to come and join us if she managed to get those models to show us. Otherwise, I would contact Mr. Onu again, and if he can show us on video, on Zoom, on those models that can be useful in our educational activity. Thank you.
Thank you very much. Professor Kato, before winding up, maybe some last comment from you.
Yeah, thank you very much. Tonight is the more than 3 hours webinar. It was very worthwhile, very fruitful for YNS, I think, especially Dr. Yuha, his philosophy, how we can be the neurosurgeon like him. I think it's very, very impressive for all of us, not only for YNS. So anyway, the study anatomy and also the daily practice is very important to become a good neurosurgeon. Thank you for organizing this wonderful webinar by Sachin and Dr. Liu. Thank you so much.
Thank you. Thank you very much.
And also the Alberts. Thank you very much. Nice presentation.
Thank
and
you.
Also, and Sharon, always the leader of the female neurosurgeon. Thank you, Sachin. Sharon, thank you, Matt. Thanks so much.
Thank you. Dr. Pilza, do you want to say something?
Yes, thank you very much for joining two young neurosurgeons from Afghanistan. Unfortunately, Dr. Shinwari, one of our best young neurosurgeons, failed to present his case, and next webinar we will hear from him. And thank you from you and Professor Kato for donating high-speed drills for Afghanistan, and arigato gozaimasu. Thank you very much. Tashakkur.
Thank you. Thank you so much for joining tonight.
Thank you. Thank you.
Thank you. What time is the Afghanistan now?
Now it's 5:50.
Okay. Thank you.
Good
time.
Thank you. Okay, good time for us. Yeah. Okay, have a good night.
Okay, you too. So,
okay.
Sachin, good night. Everybody, good night.
Thank you.
Good night.
Okay.
Good night.
Bye
Good
bye.
night. Thank you, Professor Kato.
Thank you.
Thank you.
Thank you. You should say something, please. Thank you very much. Okay.
Thank you very much. Thank you.
Thank you all.
Thank you from Sri Lanka.
Thank you very much. Thank you very much.
Thank you so much. Thank you. Thanks so much.
See you.
See you. Okay. So I finish.
Yes. Thank you, Dr. Hemanta, for joining me. Maybe next time you can present the case. Okay, next time
Yes,
you can
sure.
present the case.
Sure. I will present next time. Thank you very much.
Yes.